Hey everyone, can you hear me?
Yes.
Fantastic. Long time no see. Okay, so just getting some more students in, so we will start in a minute. Have you guys responded to the new tutors at all? Like joining them? Did they send a link to the tutor?
Yeah.
Go ahead. So they did. Okay, good. I believe they have a session today, later on?
Yes, they have to.
They have to. Okay, good. Let's go ahead and begin here. This will be the next exam. So this, the hematology exam will be on Friday and Saturday. And this exam will be next week, most likely next, probably Friday and Saturday again. So we'll do this. Cardiovascular functions. So now we move into the heart and the blood vessels disorders. So when we talk about the pathophysiology of the different heart abnormalities, most likely we are dealing with the inadequate cardiac output, so the amount of blood that comes out of the heart. So most of the heart conditions that we have are related to inadequate pumping of the heart and expelling the correct amount or right amount of blood coming out. So you could have a leak in the system, we call it. Any type of leaks that are, like bleeding, we can think of any type of bleeding somewhere. Most often in the blood vessels, maybe. We can have a problem with the electrical conductivity of the heart. The rhythms, the irregular rhythms, and we also obstruction of the flow. So the way that the flow is going within the blood vessels, you can have a blockage there or an obstruction that can lead to heart issues. And also valve problems. You can have valve problems where you have less cardiac output or the inadequate cardiac output leaving the heart. You have valve obstruction usually or incompetence, and also the muscles of the heart. You could have problems with them that can lead to failure in pumping and all that. So we will be looking at different disorders or diseases that has to do with any of these different types of pathologies that that can fail the heart. So before we get there, let's go ahead and review a little bit about the physiology, the normal physiology, and then we'll get to the abnormality so you'll understand how to relate these things together. So if you remember, the heart is a pump, and it consists of muscles, blood vessels. We have the large blood vessels within the heart. We have the aorta, we have the pulmonary trunk. These are the two largest blood vessels we have inside. Then we have the pulmonary arteries, the pulmonary veins. We have the superior and inferior vena cava going into the right atrium. And you need to understand which part of the heart have oxygenated blood, which part of the heart has the deoxygenated blood, and how we can actually, if you have a defect anywhere where where some of the oxygenated blood will shift into the left side, or the left side shifts into the right side, where you cause an imbalance in the amount of oxygen that is leaving the heart, which causes an issue. So in that regard, we can look at probably congenital heart diseases or disorders that we will cover later on. So in order, the also the talking about the different valves that we have. We know that we have the tricuspid valve on this side. We have the mitral valve coming in here. And we know all the blood coming in from the body, the lower body, going into the inferior vena cava, where we have deoxygenated blood going into the right atrium, and then deoxygenated blood coming from the upper part above your heart, and that would be through the superior vena cava, coming in to go through the tricuspid valve, and then eventually the deoxygenated blood will go into your lungs, where the CO2 will be exchanged with oxygen coming from the breathing, and then from there, oxygen will come back to the heart through the pulmonary veins, into the left atrium, and then down to the left ventricle. And with that, you pump the blood out. So that would be the cycle that you need to remember. Now, we know that we have two main systems in our body. We have the systemic and the pulmonary circulations. So when we talk about the systemic circulation, we're dealing with all the exchange of CO2 and oxygen at the level of the cells of the body, so the tissue of your body. So we need to send in oxygen to these cells and pick up the CO2 from it. We send the CO2 back into the heart, and we bring the oxygen from the heart that comes eventually from the lungs. So this circulation here, when we deal with the cells, the exchange of gases within the cells, that would be your systemic. This one here is below the heart, and this one here is above the heart, where we can go into the brain and also into your tissue above the heart also. So when we talk about this pulmonary circulation, we're dealing with the exchange of oxygen and CO2 at the level of the lungs. And it has to be very, very proficient in order to go ahead and get the blood to come in from the lung along with the oxygen into the pulmonary vein, eventually into the left side of the heart. So you need to understand these systems in order to understand the diseases in general. The other things that you need to understand is what is the meaning of systolic and diastolic and all that. Now we know that the two major phases of the cardiac cycle is the diastolic and then the systolic. So when we say diastole, which is the resting part of the phase of the heart, and that's when the heart is resting and it's not pumping. So in general, we have the diastole, and then we have the systole, and that is when the heart pumps blood through contraction, eventually pumping the blood out away from the heart into the body system. During diastole, we have the blood being filled with blood coming into the different chambers. So it could be coming toward the atria from the, for the right atrium. You get the superior inferior vena cava, deoxygenated blood, where you look at the left atrium, where you get the oxygenated blood coming from the pulmonary veins. So these are very important to understand. You need to understand what is the Frank-Starling law of heart, and that pertains to the strength of the muscles of the heart, how they contract, and this strength could be also energized through different drugs like digoxin, when we talked about that. So you need to remember that this is basically the Frank-Starling law of the heart. The cardiac output is the amount of blood that is ejected from the left ventricle, and that's how we look at it. Now you need to understand the different terms here, and we said we have the cardiac output. That's the amount of blood that comes out, and that is usually the amount of stroke volume and per heart rate. So when we say stroke volume, we're talking about the amount of blood that is pumped out of the left ventricle per minute, per beat. So every beat, you get about 70 milliliters of blood roughly to come out of the left ventricle, and it's pumped out at every beat. So if your heart rate is about 70 and your stroke volume is roughly about 70 or 75 milliliters, eventually your cardiac output will be about 4,900 or 5 liters. And that's how much the average of blood that you have in your blood, in your body, and that's how much you pump out every minute when you do it 75 times roughly, or 70 times per minute. So we know that we have the sympathetic activity taking place in the heart to create what we call the electrical activity there when we talk about the SA node, AV node, bundle of His, and Purkinje fibers and all that. And it stimulates the heart to contract using the Frank-Starling mechanism here. So we have intrinsic control, we have the extrinsic control. The extrinsic control is controlled by the vagus nerve in general, and that would be your sympathetic activity, where the intrinsic control is caused by the SA node, AV node, bundle of His, and the electrical conductivity pathway that we have within the heart. So understanding this, you will be understanding the rest of the mechanism. So these are just the different terms that you need to know. And we know that cardiac output is equals to the heart rate times the stroke volume. We need to consider the preload and the afterload and understand what they are. When we talk about a preload, we're talking about the amount of blood that comes into the heart, if it's high or low. So the amount of blood that comes into your left ventricle, okay, that is before you, and going into the vein, then eventually coming into the left ventricle. So when the left ventricle, that would be your preload, and then we pump it out. When you pump out the preload, then eventually you are faced by the afterload. And the afterload is the resistance that you get within the large blood vessels, including the aorta and then the other blood vessels that you have. So when you have vasoconstriction, you're going to increase the afterload in this case because you are increasing the resistance in general. And it's also dependent on the contractility of the heart. So this is just the physiological changes that happens during your normal heart cycle. So when we say a cycle, that is basically one heartbeat. So every time the heart beats, you go through all these different changes here, where you look at the valves, you look at the, so in this case, we look at the end diastolic volume. So the end diastolic volume is the amount of blood that you find in the left ventricle after diastole, where the end systolic volume is the amount of blood that is ejected from the left ventricle, and usually you have a leftover amount after you eject in the left ventricle. You do not eject everything that you have in the left ventricle at one time. So the amount that is ejected, okay, that would be, and then we find out how much left in the heart after you eject your stroke volume, then that is referred to as the ESV, or end systolic volume. So end systolic volume is the amount of blood that is left. So if you have a heart failure, eventually the end systolic volume is going to be more because your muscle is not pumping all the blood that you need. And it's pumping a lot less than, so your stroke volume is down because you're not pumping enough blood coming out because of the failure of the left ventricle. Okay, so these are the different phases here that you have to go through and understand. Ventricular filling is the amount of blood that goes into the left ventricle and the right ventricle, and the amount of blood that fills the ventricles. So ventricular filling mid to late diastole, that's what happens. That's when it's happened. It happens mid to late diastole. That's when the left ventricles are filled, left and right ventricles. So in here, it talks about the isovolumetric contraction, and this is the amount of the strength of the contraction that you contract with the valves closed. So your ventricles cannot start contracting before the valves open. So that is referred to as isovolumetric contraction. Then the valves will open. So after the volumetric contraction happens, the valve will open, and then you have the ejection phase happening. So the ejection phase is the amount of blood that ejects out of your ventricles through the valves. So isovolumetric relaxation, then also after the muscles relaxes, and then eventually, you know, after you close the valves, then the muscle relaxes, and then you open up again, and you go into the ventricular filling. Then the filling comes into the valves again. So these are just curves kind of doing systolic and diastolic. When I see that little bump over here, I know it's systolic going up in this case here. All right, and diastolic would be right down here where it is not pumping here. So these are the heart sounds here, where you hear the first sound and the second sound. If you remember, the first sound gives you the sound that you hear of the closures of the of the atrioventricular valves. So the tricuspid and the mitral valve, when they close, eventually will give you the first heart sound. Then the second heart sound will come when your the semilunar valves closes, and that's where the second heart. So these are kind of the locations for them. And this is the EKG diagram of one complete cycle. So by the time you finish into the diastole, which is over here, and then you come into another P wave. So PQRST wave, and that's where you go with. Now, eventually, at the end of this course, I'm going to take you into different arrhythmias. We're going to understand the arrhythmias. We need to know which are the most common arrhythmias that you will be seeing as nurses. And I will make you understand what is the EKG do, and then we'll talk about the different arrhythmias. That will set you up, actually, after we talk about it, to sit for a certification exam if you want, which is the certified EKG tech type of certification that we offer. So by the end, hopefully you should be ready to even sit for that if you want to take it. So here are some of the forces determining oxygen consumption. That means, what are some of the factors that can relate to oxygen consumption? We have the heart rate, we have the preload, the contractility, and the afterload. Exactly what I covered earlier. And we said the heart rate is the number of beats per minute within 1 minute. So 70 to 75 is the average. So the harder the heart has worked, the more oxygen it requires. So you need to understand, the more it pumps, the more the muscles require oxygen. So if you have any coronary arteries that are not working, and we know the coronary arteries actually supplies the muscles of the heart with blood and oxygen. If the coronary arteries are not working well, and you have a blockage somewhere, you know that the muscles of the heart are going to go into what we call ischemia, and probably eventually you can get into a myocardial infarction because of that. So the heart rate is very important to keep it within normal range. You don't want a tachycardia, and you don't want any of the other arrhythmias, because the more it pumps, the weaker the muscles become, and the more oxygen is required to the muscles. Preload, I said, is the amount of blood returned to the heart, so it can be pumped through the left ventricles, and that would be your preload. And then eventually, contractility is the ability of the muscles to contract, and then the afterload would be the resistance after the ejection. So after you eject, what kind of resistance are we getting? So again, with vasoconstriction, you're going to get more resistance than vasodilation. Vasodilation, it opens up, so you don't have enough resistance going on for the blood to go and be pumped to the outside. So, so all these would be factors affecting heart rate. So atrial reflex would be the reflex of the atria to pump. Autonomic innervation, hormones can also play a major role in your heart rate. Then we have factors affecting the stroke volume, and we said the stroke volume is the amount of blood that is ejected every beat. So usually it's about 70 milliliters of blood that is ejected. That's normal. And then we still have some end diastolic and systolic volume of blood remaining in the ventricle after the systolic volume has been ejected. So you never eject everything that you have in the ventricle or in the ventricles. You always have an end diastolic or end systolic volume depending on if it's the right ventricle or the left ventricle. So venous return is very important to come and decide if if you have any resistance going. So preload, afterload contractility, all that end diastolic volume, end systolic volume, all that has a lot to do with the stroke volume, how much will come out of your heart, and that would give you the cardiac output eventually, which is heart rate, all these factors that can lead that can affect the heart rate, and all these factors here that give volume. So all that can cause a how much oxygen are you consumed and how much oxygen you are needed for the muscles of the heart to contract well. So systemic versus pulmonary vasoclature circuits. This is just showing you how the pressures in different parts of your vessels, blood vessels. The aorta has the highest pressure, as you see, you notice here. So the aorta is the highest pressure, even at your diastolic. So after you pump the blood and the aorta is under diastole, you have about 100 milliliters per mercury sitting there, right there. The large arteries are the same thing, in general. So the large pulmonary trunk, small arteries, you get smaller. And then as you, when they talk about large arteries, they talk about the, we call them medium size. So like the pulmonary arteries, talking about cephalic artery, hepatic arteries, and all these things in your body. Then you get smaller into the smaller arteries, and then even eventually to the arterioluses, and that's where you have the smallest arteries that you have that joins the capillaries here, and then eventually venules. Then small veins, large veins, vena cavas, and so on. And these are the pulmonary arteries right there with a little bit pressure here in them. This graph shows you how much pressure we have within these different, different blood vessels. You also need to understand the pressures within the blood vessel. We need to understand what is a hydrostatic pressure, what is an oncotic pressure, and what is the filtration pressure. So hydrostatic pressure is the amount of pressure that you have within the artery that's pushing out. So inside here, I have a hydrostatic pressure pushing filtrates outside of the blood vessels. Usually the capillary is the one that has pores in it, and that's where you have filtration going in and out of the capillary. So hydrostatic inside, the arterial end of the arteriole, which is right over here, and the venule connects with the capillary right over here. The arteriole has about 8 millimeters per mercury, and the venule has -7 millimeters. So as you go up, you decrease the pressure further and further, and the venules have, then eventually the veins have in the minus type of pressure, so barely the blood can reach the right atrium. The oncotic pressure is the pressure inside exerted by the plasma proteins. So inside this blood vessels, I have plasma. Inside the plasma, I have proteins. The proteins actually attracts water, and it brings the water in. So the pressure will be moving in this direction because the proteins are sitting here, and they will grab onto the water coming in. So all the water will be going inside due to the oncotic pressure. Then the filtration pressure is going in this direction. So I filter the stuff that I have inside the capillary outside. So these are the different that you need to understand within a blood vessel. Like if you increase the hydrostatic pressure, which is the regular blood pressure that you have. When I increase my blood pressure, eventually I'm gonna, eventually push things out of the capillary outside to my tissue. Okay, so when you increase people's blood pressure, you can end up with edema around the tissue where you have capillaries. So that's why your increase in blood pressure can lead to that. Oncotic pressure, increase in oncotic pressure can pull all the way inside the blood vessel and can lead to hypertension also, because the volume inside the capillary will increase and then you have hypertension. And the tissue around it will become dehydrated and some of the cells will collapse because of that. All right, let's go ahead and start with some of these disorders and see how we can understand them. The first one we're going to talk about is heart failure. And heart failure is when your heart fails to pump. That's basically what it is. So when you fail to pump, usually it's divided into the right heart failure or left heart failure, depending on where the issue is. Now again, most of the causes are related to the different factors or risk factors that we covered on the first slide. So if you have a heart muscle that is not getting enough oxygen because of the coronary arteries, eventually you can fail. If any of these valves that you have inside your heart are not working right, then the heart can fail. If the afterload is high, okay, then the heart can fail because it's trying to pump and it's unable to pump, so all the blood flow will go back into the ventricles, and then you have all the blood that is accumulating in the ventricle will seep into the muscles of the heart, and eventually the muscles of the heart will become congested. So you end up having what we call congestive heart failure. High blood pressure can cause this. People that have high blood pressure, that is the afterload. So when you have high blood pressure within your blood vessels, eventually all the blood will backflow into the ventricle. And then eventually the ventricle will leak. Some of the blood will filter out through diffusion into the tissue around it of the muscles of the heart. And then you end up having water congested in the muscles of the heart. And you have congestion, swelling of the heart, which is hypertrophy of the heart. Okay, so there are different factors that we will talk about as we go on, why your heart can fail. What are some of the physiological abnormalities, and this is referred to as the pathophysiology of the heart in order to get heart failure. So congestive heart failure in general, again, that is what we are dealing with. So we can think of a valve that is not working. If you don't have a valve that is working, everything is going to be congested, retained in the same area. You're not going to pump things. So that would be one of the major reasons why the heart can fail. When I say congestive heart failure, that means you're going to have backflow of blood congesting within the muscles of the heart. And those muscles of the heart becomes like sponges with all that blood congested within them. We have two types, either your systolic dysfunction or diastolic dysfunction. Again, systolic, that means during your ejection, during your pumping. So an MI can cause this. An MI, myocardial infarction, that means you have a blockage in one of the coronaries that led to necrosis of the muscles of the heart. And eventually from that necrosis, eventually you end up with an infarct. When we say an infarct, that means it's a necrotic muscle cell. So if you have a muscle, an infarcted muscle cell, eventually you can fail. So you're not going to have all the muscles, all the fibers of the ventricles there to pump. So you're going to have less heart pumping, and many of that blood will leak out into the tissue of the muscles of the heart, and you're going to end up having congestion because of that. If you have decreasing contractility, a decrease in contractility eventually causes decrease in ejection fraction, and a decrease in ejection fraction, and decrease in ionotropy during systolic. Ionotropy is the ability for the muscles of the heart to contract. So using ions basically within them to contract. So decreased contractility involves decreased beta receptor regulation. And we know that the beta receptors are the ones that actually work with epinephrine in order to increase the heart rate. So when you decrease this, then the heart rate will decrease. And when you have a lower heart rate, eventually you give time for congestions to develop. So bradycardia can lead to congestive heart failure. So you don't want to have a long-term bradycardia because the pumping is not in timely manner, and the blood can seep. You're given a chance for the blood to seep into the muscles of the heart and then eventually causes congestion. And also decreased ATP production. And we know that you need ATP to be produced inside the cardiac muscles in order to give the muscle energy to contract. So when you don't have the beta receptors working, eventually you're not going to contract the muscle well, and you're not going to produce enough ATP within the muscle cells for it to contract. During diastolic, hypertension and cardiac artery disease are most common. So if you have hypertension, then again, you're not pumping anything. And then again, you're backflowing all the way to the diastolic phase. So now during diastolic, we have the blood filling into the ventricles from the atria. It's sitting there waiting for the systolic to come. And because you have hypertension, you have an increase in afterload. So the blood will stay in the ventricles. So during diastolic, you'll have a dysfunction because of the hypertension. And coronary artery disease that leads eventually to a blockage and then necrosis also of the muscles. Diastolic is more in elderly because they have hypertension and they can have a history of MIs. Disorder of myocardial relaxation with a non-compliant ventricles that does not fill effectively. So you could have valve issues also that relate to not filling the ventricles correctly. So you have decreased cardiac output, congestion, edema, with normal ejection fraction possibly. So the ejection fraction that goes out from the ventricles could be normal, because that's the amount of blood that goes out, okay, when the heart is congested, but it doesn't mean that it will be within normal volume. So here are some of the congestive heart failure compensation mechanism. So if you have a heart failure, eventually there are three pathways where we can compensate with that. First of all, the baroreceptor responses, which is the sympathetic. If you have heart failure, eventually the baroreceptors will kick in and tells the sympathetic nervous system to increase the heart rate and increase contractility. So that's how it compensates itself when you have heart rate. So if you have a patient that you suspect, heart failure, eventually they can have tachycardia. And in order for it to increase the contractility and pump enough blood outside. So that would be compensated with tachycardia. The other compensation pathway is the RAAS activation. Now we know that when you activate the renin-angiotensin system, eventually you're going to decrease the GFR. So because you have reabsorption of sodium, you're going to have reabsorption of water to follow the sodium. So you have less urine being produced or excreted, and then you have fluid retention. So when you have fluid retention, you have increase in preload. So again, retention, fluid retention within the blood vessels that you have before you get into the right atrium. That increase in preload can cause to increase cardiac output also. The other mechanism would be increased ventricular wall tension. So to compensate, the ventricle to compensate, it increases the tension and it increases fibers, the myofibers within the ventricle wall. And when you increase the number of myofibril fibers, eventually you enlarge the blood vessel, not because of the fluid, but because you're increasing the protein and the myosin and the actins. By increasing that, you're going to end up having a enlarged heart because it needs to compensate on the contraction within the heart, and that would increase your cardiac output by increasing the contractility ability of the heart. Any questions so far?
I just had a question about did you say that we were able to sit for the EKG monitor test?
EKG certification. Yeah.
Oh,
So,
okay. Great.
yeah, you can. I mean, we have a course where you can sit for it. I think it's called AHS 245, where you can sit for it and then get certified at the end. So
Wow.
with me giving you a nice, like overview of the arrhythmias, you'll be ready to sit for it a lot faster than going through the course, and you'll do better.
Okay, great. Thanks.
Yeah, so we have this connection with the AHA, American Health Care Association, where they administer this test, and you can sit for it and become an EKG tech. So, yeah, it's a good thing to have, actually. Any other questions so far? All right, moving on. So, so here are some of the things that you need to understand when you have a heart failure. So, left ventricle failure is the most common. So you have left ventricular failure. So that could be due to, like stenosis of the mitral valve. So mitral valve could be stenosed, and with that, you're not going to have enough pumping of the blood. Or the walls of the ventricle, okay, the left ventricle, becomes ischemic and eventually necrotic, right? That can lead to the failure of the ventricle. Left failure often leads to right failure. So left failure is the most common cause of a right failure, heart failure. So here's what I'm trying to say. If you have a left ventricular failure, this would lead into the right ventricle to fail because you have backflows of blood. And everything's going to backflow to the right ventricle. So if we ask you what is the most common cause of right heart failure, you say left heart failure. So if we have a left ventricular failure, so the forward failure would decrease the cardiac output. So I don't have enough blood being pumped through the ventricles, the left ventricle. So that would manifest as confusion because you don't have enough blood going into your brain. Fatigue, tiredness, tachycardia as what? A compensatory type of mechanism like we just mentioned. Decrease urine output like exactly what I mentioned. And decrease peripheral circulation because you have backflow going in there. So you're not going to have enough circulation going places. So these are the forward failure. The backward failure would be the congestion of the blood behind the pumping chamber. So that would be in your extremities and so on. So left failure, you cannot pump enough blood. So when you don't have enough oxygen reaching your tissue in general, and can lead to all these problems here, and eventually those compensatory type of mechanisms that we discussed in the slide before.
So left heart failure is CHF?
Left heart failure is when the left ventricle fails. Now, is it always congestive heart failure? No. You could have a left ventricular failure due to other reasons. So you don't have to have congestive heart failure all the time. So congestive heart failure is by itself, separate, okay? But could your left ventricle fail for other reasons? Yes. You could have an MI. When you have an MI, you have ischemia, and then you have a necrosis of the muscles of the ventricle, and that take away from the number of fibers that contracts, and then you fail. Understood? And also you could have failure if the valve is not opened well, because you can have enough not enough blood being pumped out, like in the case of aortic stenosis. If you have an aortic stenosis, then the stenosis, that means that the valve doesn't open well, and not enough blood can go out from it. So that would end up having the left ventricular failure, because all the blood's going to backflow within that, and that would damage the muscles. And you can have congestion because of that, yes. But congestion is not, left ventricular failure is not always due to congestion. Okay? So here's your left side now. So left side, we're talking about the left ventricle. So forward and backflow. So let's look at the forward, so this is the forward. I said we decrease cardiac output, we decrease tissue perfusion, so you have less oxygen reaching that. Then you have the RAAS activation. And with that, you have fluid retention. With the fluid retention, eventually it can lead to increase in left ventricular preload, because the amount of blood that you have before you eject it will decrease. Backwards, the backward flow, you have less ejection fraction, of course, which lead to increase in the left ventricular preload due to fluid retention. Left atrial pressure, okay, because you're not getting any blood to come into the left ventricle from the left atrium. All the blood is sitting right there. Then you have also pulmonary pressure, because everything is back and flow into your lungs. So you have increase in the blood vessels within the lung, the pressure within the lungs. You're going to end up having pulmonary congestion. So think about the backward pathway, that you have blood coming into the left ventricle. All that is going to backflow. And eventually you have an increase in right ventricular afterload because of all that circulation that's taking place. So eventually you're going to have what we call right ventricular hypertrophy, because it gets enlarged. So what is the mechanism of it getting enlarged? You're getting a signal that you're not strong enough to push. So you're going to get left ventricular hypertrophy by increasing actually the fibers of the muscles. It doesn't have to be congestion. You can have hypertrophy due to increase in the fibers, protein fibers within the muscle, because you're trying to compensate for the, you want it to pump more. So here are some diagrams for you. So this one is this is normal hypertrophy. This is hypertrophy. Look how large this ventricle becomes. Very huge. This is a smaller one here. So this is just like a necrotic type of tissue that you have that eventually leads to left ventricular failure. Any question on this mechanism here? All right. So this is your left heart signs and symptoms. So if you have a left heart sign and symptoms, so we're thinking of what? Congestion in the lungs, right? Not enough oxygen reaching your tissue because you're not pumping enough. So what's going to happen to you? Well, you're going to have difficulty in breathing because you have congested heart failure, congested lungs. So this congested lungs is not going to, the perfusion of oxygen and the exchange of oxygen with CO2 is going to be way down. So you're going to end up having dyspnea, paroxysmal nocturnal dyspnea, which is basically, it wakes you up at night. You're going to wake up because of the, not able to breathe. It's going to lead to orthopnea. Orthopnea is difficulty in breathing while laying down. So these people, when they lay down, their fluid in the lungs will just fill up all the lungs, and they will have difficulty in breathing. So when you sit up like this, or you lay down into an orthopnic position, eventually you drain the fluid down in the bottom of the lung, and you'll have some areas that don't have any fluid where you can breathe from. So you breathe better that way. Tachycardia as compensation, exertional dyspnea, that's after exercise and so on, you shortness of breath. You end up having your fatigue, you're confused because there's not much oxygen going up in your brain. You're restless, you become restless because of the amount of oxygen reaching your brain also. Fatigue, cyanosis, you don't have enough oxygen going tissue. So you're gonna have more of a CO2 there, so you become cyanotic because of that. So with the pulmonary congestion, what's gonna happen to you is you're gonna cough, you're gonna be coughing all that fluid out. You're gonna hear crackles in the lung as you auscultate. So you put your stethoscope on the lung, you're gonna hear some crackle sounds. Crackle sound is just like taking you're gonna hear like that kind of sound, when you listen to the with the stethoscope. Patients are gonna wheeze because of the trying to get as much oxygen as they can, and because of the congestion also. You're gonna have sometimes a bloody sputum comes out because you irritate the airways too much by coughing and all that. Eventually you scratch your airways, and then you eventually have blood in the sputum. And then tachypnea, you're gonna hyperventilate in a way to compensate for the oxygen that you don't have. So that would be your left-sided failure. All right, so let's go into the right-sided failure. And what happened when you have a right-sided heart failure? Now you're thinking about the right atrium and the right ventricle. Most likely we're talking about the right ventricle. That's when it fails, because we need to send the blood from the right ventricle up the pulmonary trunk and eventually to the lungs. So if this fails, then you're not going to be able to send anything or much to the pulmonary trunk, and everything's going to backflow now. When you have a backflow, you're going to congest the tissue that you have. So you're going to increase the preload there. So the preload is going to be increased because you're going to have plenty of fluid sitting inside your vena cava. And the vena cava is eventually going to have leakage of blood, or actually the fluid coming out of the veins, the venules. So we're talking about the veins here in general being congested and backflowing. So you're going to have increased pulmonary vascular resistance, okay? So the pulmonary vascular resistance, so if you are not sending enough blood into the lung, eventually they're gonna constrict. So when they constrict, you have more of a resistance in the lungs. You're gonna increase the afterload, okay? So the afterload after the, when you do all that, eventually the cycle will get into the left ventricle, and then you're going to have eventually not only the preload, but the afterload will be increased within the right ventricle. It's going to get enlarged. When the right ventricle gets enlarged, you call that cor pulmonale. So the right ventricle hypertrophy due to a secondary cause, okay, in this case, you could have a myocardial infarction or something, then you have what we call cor pulmonale. And then you end up having the right ventricular failure. So, so you have backward congestion. You need to know that. You have less cardiac output coming out of the left ventricle because you're not going to send much to the lungs. The lungs is not going to send enough blood back to the left side, and you're going to have decreasing cardiac output. You're going to have decreasing tissue perfusion in the lung also. Not only in the lung, but the outside, your body will not get enough oxygen. It's a cycle, you guys. So if I can't send blood to the lungs is not going to send enough blood back into the left side. So eventually the left side is going to fail. See how? So when you look at a patient that has right heart failure, all that blood backing flowing into the tissue, eventually you're going to have edema everywhere. So these people, you're going to get what we call pitting edema, okay? Which is, pitting edema is when you put your finger on the skin and you form what we call a dentation in here. And that is one sign of having fluid in your skin. If you push on the skin and you see nothing, then it's maybe inflammation more than fluid. So that's one sign that you can see if you have fluid congested in the tissue. You're gonna have hepatomegaly. Hepatomegaly is enlarged, enlarged liver, because we know the hepatic vein goes through it, and the inferior vena cava is attached to the hepatic vein. So all that, you're going to have edema, you're going to have ascites. Ascites is fluid, accumulation of fluid in the abdomen. All right. So that's one sign also. Jugular vein distension. So because of the backflow, eventually your veins, the jugular veins, will be distended because you have backflow going into the veins. So hepatomegaly, enlargement of the liver, impaired mental functioning because you're not getting enough oxygen going into your tissue. So right heart failure eventually can cause a left heart failure or decrease in cardiac output. Splenomegaly, hepatojugular reflex test, and that is when you push on the liver, and then eventually you see a pulsation in the jugular vein because of the fluid all over your body. So here's your mechanism of the right ventricular failure. So backflow, backward, you have decrease in ejection fraction because you don't have enough blood going out of the right ventricle. You have increase in right ventricular preload, okay, because it's all back behind, so your preload is higher. You have increase in atrial pressure, arterial pressure, again because it's trying to compensate in this case to to balance out the venous pressure. So you have systemic congestion with the right heart failure. The forward, you're not going to send enough blood into the lungs. So when that is not enough, then the lung is not going to send enough blood to the left side. So your cardiac output is going to be less of the left ventricle. And then you're going to have less ventricular cardiac output and less, output in general, less cardiac output. And then you have less decreased tissue perfusion because you don't have enough oxygen and blood going out of the left ventricle. So the ARAS is going to be activated, fluid retention. Again, above all that, you're going to have more fluid retention. So you tell these patients stay away from salt for sure, because they're already activating the RAS. If they take more sodium, you're going to have more fluid retention. They're going to be in a worse situation. So here's a picture for the right side heart failure, and it's again, it's referred to as cor pulmonale sometimes. So in this case, you have ascites, you have fatigue, right? Increased peripheral venous blood pressure. So all that's going to be down here in the leg and in the liver and all that. Ascites, fluid leakage from all over, enlarged liver and spleen, maybe secondary to a chronic pulmonary problem. Okay, could be, you could fail. Okay, so if you have congestion, if you have a pulmonary congestion, now people that smokes, okay, if you smoke, you're going to end up having cor pulmonale because of the smoking, because your lungs are not working well. What's going to happen? You're not going to perfuse well. So all the blood is going to backflow eventually into the right side. So you're gonna end up with right heart failure because of smoking, because you have COPD or something. So people that are smokers, they're not going to get only COPD. They can get right side failure also. So they're going to have distended jugular veins, like I mentioned, because of the backflow. Anorexia, complaint of GI distress, and weight gain. Now the weight gain has a lot to do with the water. So we need to always weigh these patients and see if their weight increases again more than 5 pounds a week. You need to tell the physician has to know in order to put them on some diuretics to get rid of that fluid. Otherwise, they go into serious heart failure, and then they can die because of that chronic heart failure. And then you have edema in the legs. So cor pulmonale, right side failure secondary to intrinsic pulmonary disease like emphysema, like I said. So emphysema, scarring condition along chronic embolism, any of this problem here can give you what we call cor pulmonale, which is right heart side failure due to lung issues. So here's a picture of edema. This is what we call pitting edema. So you put your finger in here and you push down. You see that dentation right there? Because this is all fluid here. So you push in and the skin will go in there and retract inside because of the fluid. That's called pitting edema. So with the right side, how does your system compensate because of that? So if you have a decreased myocardial function or failure, eventually decreased cardiac output, eventually decrease in the blood flow to the kidney, then you activate the RAAS system, you increase the blood pressure there, you're going to increase the cardiac output and eventually increase the cardiac workload. If you go decrease in cardiac output and you're going into the baroreceptors again, you activate the sympathetic, that would increase the heart rate and then eventually increase the blood pressure. When you increase the blood pressure and the pulse, which is heart rate, you increase respiration also to compensate with that. You increase the ionotropic effect of the muscles. You increase cardiac output, and that would increase the cardiac workload eventually. So both systems can activate the aldosterone system, and the aldosterone will increase the reabsorption of sodium. So you have sodium retention, potassium excretion, water retention. ADH will be released eventually to get rid of that water retention, and that would increase the blood volume, because of the retention of sodium and water. And that increases the cardiac workload eventually. So now we talk about congestive heart failure. So congestive heart failure, if we talk about it, then based on a progression of the symptoms, and what we deal with this, how serious your congestive heart failure is dependent on the progression of your symptoms. So we look at your symptoms, we look at the phases, we call it. How tired are you? If your activity limitation, you have activity limitation, congestion, edema, shortness of breath. So we kind of tell you like it's a severe condition when you're as these things increases in intensity, then we know that you are getting worse and worse with congestive heart failure, and you could need to be hospitalized. But otherwise, you ask the patient to continue doing their activity, and you put them on medications and let them, stay home and deal with this. But they have to take their medications and do what they should be doing. So how do we diagnose a congestive heart failure? You do a chest x-ray, you're gonna see a big heart, okay? On the x-ray, you can see an enlarged heart. You can do an echocardiogram. An echocardiogram, who can tell me what an echocardiogram tests for?
What was the question?
Who can tell me what does an echocardiogram do? What is the purpose of an echocardiogram?
So it's actually a probe that you actually can stick in the heart and look kind of on the inside and check for valvular movement and things like that.
Okay, that's a catheter. When you put a probe inside the heart, you should measure the blood pressure.
Well, but you can do it via TEE. That's what it's for.
Mm-hmm.
Isn't an echocardiogram to listen to the heart?
Yeah, this is basically an ultrasound. So it's an ultrasound to the heart. Echo. So you put a microphone on the heart. This is when after you do a stress test on a patient, you take them right away to the bed and you let them go on the side, and you put that microphone on their heart to listen to the basically valves, if the valves are working well or not. So murmurs, you can look at also the muscles of the heart, okay, if they are contracting well. You look at the valves of the heart, if they are opening and closing well. So you listen to the beating of the heart. That's what you do, if it's normal or abnormal. So you test for the muscles of the heart, and you look at the valves of the heart also, if they're working well. And then you can do an EKG. And EKG usually, when you have enlarged ventricles, you're going to have a widened QRS. Okay, if you remember from EKG, which we will talk a little bit more on it at the end of the lecture, the P wave detects the contraction of the atria. The QRS detects the contraction of the ventricles. So if you have a delay in the contraction due to the congestion, you're going to end up having a widened EKG, widened QRS complex. Okay, so again, so what else do we look at? We look at the increase in the B-type natriuretic peptide. Okay, natriuretic peptide is a peptide that is released by the atria. Okay, to see the ability of the atria to contract or not, and it has to do with the sodium also, sodium level in the blood. So that is basically the ability for the atria to contract, and that would be, or stretch, that what would be the natriuretic peptide level. Then we look at the elevated during elevation. Well, it elevates during chronic heart failure only, which is the natriuretic peptide. We look at the severity of symptoms used to identify in the 4 classes of stages. So we have 4 stages, moderate, mild, severe, or chronic. So you look at what kind of congestive heart failure you would have, and we stage you according to the stage. With that, we determine a prognosis, therapy, and monitoring the patient. So we look at all that, we do all that, and then that's how we classify you into what stage of heart failure, congestive heart failure you are in. So what do we do to treat you? Again, congestive heart failure, we talked about this last quarter when we talked about the heart. And we talked about the different, we need to increase the stroke volume, increase left ventricular ejection fraction, increase contractile forces. So we give you beta blockers, we give you digitalis, we give you ACE inhibitors, all that we discussed last quarter in order to increase the cardiac output eventually. We talked about this last quarter also with the therapeutic management of congestive heart failure or heart failures in general. Physical exercise, quitting smoking, weight loss, sodium diet control. This is a therapeutic management. We discussed that last quarter. I can bring some of that on to incorporate some of this information into the questions. So keep in mind, just review it again while you're doing this. So this is what you need to assess as a nurse: past medical history. You see if they ever had any type of issues before they become congested. The medication they're taking, activity intolerance, excessive fluid. So you look about all that. any disturbance in sleep, impaired gas exchange, anxiety, functional health problems, cold, diaphoretic skin, tachypnea, tachycardia, crackles of downward distension, and restlessness. So you look at all these when you assess somebody with congestive heart failure. So your intervention would be controlling and making sure that cardiac output is better. So you always look for the medication they're taking, make sure that they're on the medications, decreasing the venous return. You know, you don't want to have a lot of fluid with the right side failure. You need to improve the left function, basically. You need to improve the left ventricular function by probably reducing the backflow if it's right heart failure, and improving the, increasing the strength of the left ventricle in order for it to pump blood. Sometimes you have to put them in Fowler positions so they can breathe better. Decrease the afterload. In general, diuretics can cause this. Eventually, the afterload becomes the preload, by the way, you guys. So afterload is after. And if it can circulate all the way to become a preload. So improving gas exchange and oxygenation, make sure that they are on oxygen, improve cardiac function, reduce anxiety. So reduce anxiety and all that from them. So decrease afterload, you give them vasodilation, dilators, ACE inhibitor to you know, so vasodilators to open up, ACE inhibitors to inhibit the RAAS system there. Decrease pulmonary congestion, improve cardiac function, positive inotrope. You know, we talked about this, reduce anxiety with morphine and all that. So this is your intervention in general: decrease edema, decrease shortness of breath. This is your goals, basically, long-term goals to decrease all that and increase exercise tolerance, drug compliance, and no complications. That would be your monitoring and your overall goals in general. Acute, right away, you need to establish quality of life goals, symptoms management, conservation of physical, emotional energy support system are essential. All right, so this is the coronary artery disease. Look at this here. All right, let me go over a couple more slides, and then we will stop at MIs, myocardial infarctions. So, so when we talk about coronary artery disease, we're dealing with the coronary arteries, and if you say coronary artery disease, you're talking about any disease that leads to a coronary artery problem. Ischemic heart disease is also referred to as coronary artery disease, is also called ischemic heart disease because we have less blood supply to the tissue of the heart, and that can lead to that. We talk about ischemic heart disease in general. So this is the biggie in the Western world because we get heart attacks a lot. But usually you want to talk about reduction of blood supply to the heart first, and then you talk about MI. So you become ischemic first, right? So different reasons why you become ischemic. Coronary arteries could have a blockage. It could have increase in fat buildup, or you could have vasoconstriction of the coronary arteries. Any of these three can lead to ischemia eventually of the muscles of the heart. So when I say atherosclerosis, you're dealing with fat buildup. If you say acute versus chronic ischemia, that means we're talking about you know, ischemic. It means less amount of oxygen reaching the tissue. Could be acute or could be chronic. So the four basic pattern, again, you can have an angina. Angina is basically the chest pain that you get when you have an ischemia. Myocardial infarction, that's the heart attack. That's when you have an infarction actually develop. Chronic ischemic leading to congestive heart failure. So ischemia eventually can lead to congestive heart failure because the walls of the muscle will not contract as well. And then you can have sudden death from arrhythmias. So arrhythmias could be also a major cause that can come out of the ischemic heart disease. So when you get a clot or a coronary artery disease, you could have eventually an arrhythmia because of that. We'll talk about different arrhythmias as we go on. So atheroma, okay, atheroma, remember, not arth. Arth means joint. Atheroma, fatty tumors. You're gonna have fat buildup right in the artery, okay? We're talking about coronary arteries here. You can have atherosclerosis, narrowing the heart vessels, angina, suffocation, myocardial. So here's what we have here. These are the walls of the artery, adventitia, media, and intima. Atherosclerosis can lead to buildup of lipids. And fixed coronary obstruction, typical angina can give you this. Like you have a partial, like almost, you have a little opening for the blood, but not enough. You can have platelet aggregation problems right inside the coronary artery also that sits on the top of the fat also. So, so you can have a plaque or a plaque in this case, disruption. You can actually bleed through the plaque, the cholesterol plaque, and then eventually having a thrombus in there. And when a thrombus comes in, then it blocks the whole thing, and then you end up having what we call occlusive thrombosis. So that's a full type of thrombosis that gives you an acute coronary syndrome, which is an MI. So we know the difference between embolus and a thrombus. An embolus will be a traveling thrombus, basically. So these are different types of lipid molecules that you have in your body. And these are very important to understand, you know, and I think I covered that with you before, but let's review this. So in the liver is where we produce cholesterol, and, you know, and then that's where we actually produce everything else. All these little molecules here are produced right there. So eventually within those molecules, we have different things that sits in them. We have triglycerides, we have phospholipids, we have protein and cholesterol sitting in there. And we need to make sure that we don't have enough triglycerides in there to be more healthy. So the less triglycerides we have, the healthier. So the high density lipoprotein, which is this, we have the least amount of triglycerides, we have the most amount of proteins, as you notice, and lesser amount of cholesterol. So the LDL would have 25% protein, you have 45% cholesterol, and then you have 10% triglycerides, you know, which is a little bit better than this one here that has 60%. This is a very low density lipoprotein. You have plenty of triglycerides. This one has the most triglyceride. That's the chylomicron, by the way. This goes away. This actually comes in your blood as soon as you eat. So after you eat, eventually your blood will look creamy because of those chylomicrons. And eventually they go away, and then you end up having these things after that. So as you create these, you want them to be balanced. This is a chart where you want your cholesterol to be less than 200. You want your LDL to be less than 100. Normal 129. The HDL, you want it to be actually greater than 40, 60 here. It says greater than, but greater than 40 is acceptable. Triglycerides, you want it to be less than 150. So this is the mechanism of the coronary atherosclerosis. Again, the buildup of cholesterol that comes in and sits in the artery. Basically, it comes in and sits there as soon as you have like damage of the blood vessel. So too much cholesterol and too much triglycerides can sit right over here for you. especially the very low density lipoprotein and the LDLs. VLDL and LDL should be very low because these are the ones that actually lines the wall of the arteries. As soon as you do that, eventually they scratch the wall and they end up having them sitting in there. And they start building up as we go on. So you have some of the cells coming off the wall, and eventually they're going to be in the blood vessel. And when they do that, then eventually they can lead into a clot along with everything else. So ischemia, again, oxygen supply insufficient, coronary perfusion insufficient, vasospasm can cause this. You can have an acute occlusion, okay, which is just partially occluded, or you could have a myocardial ischemia. Usually you have vasospasm, hypoxemia, or low perfusion that can lead to any of the MIs. So we talked about these different type of, excuse me, MIs. This is called predictable or stable. That comes after stress or exercise. Unstable when you're sitting down at rest and you get chest pains. And Prince metal is the worst one. That's the one that's triggered by the exertion and also caused by spasm of the blood vessels and not just by narrowing of the blood vessels. Okay, we'll stop here and I will start here on Monday. So most likely I will finish this by Wednesday and then your test will be over the weekend, next weekend for this chapter. So on the weekends we take exams in general. That would be system in general.
So this Friday and Saturday, what's our test gonna cover?
So this Friday and Saturday, I said just hematology. So the hematopoietic type of functions there.
Oh.
So just the hematology chapter, which is chapter 3. So this is chapter 4. So make sure you go over the PowerPoint big time with chapter 3 because some you have a little variation from the book is there, but I added a few things if you notice also. So make sure you know that. Make sure and the PowerPoint should be your guide. Do your focus points from there and do your study guides from there. Now, again, the tutors have answers for that, so you can go there and work with them to get that. I recommend it. If you can't make it, that's fine. They can see you one-on-one also, so whichever you like. If those times don't work for you, send them an email, see them one-on-one. So you have today and tomorrow to prepare for that. And also Friday. I mean, you don't have to take the test until Saturday evening if you want. So you got plenty of time to study if you're not ready yet. But if you're ready, it'll be available at 8 o'clock in the morning on Friday to take it. Okay? And pharmacology will be on Saturday and Sunday. So, which is the antibiotic only. Antibiotics. Any other questions, concerns?